This conference will now be recorded.
Good evening, everybody. This is Joe Gallo from ASnCan, and welcome to our once each month special presentation. We've got a very interesting guest tonight, but I want to go over a couple of admin things before we get started. First off, I'd appreciate if everyone would please mute your system. There won't be any real opportunity for any interaction verbally throughout this, and strongly prefer that you also turn off your webcam so it doesn't create a distraction for those who are watching. This system will also allow you to put questions into the chat. The several moderators will manage those questions and present them to our guest. And the only other thing I want to go over is just the basic disclaimer that, excuse me, this presentation is not intended to be any form of medical advice. It's intended to be predominantly some education. So anything that you hear or see here that you are interested in, we strongly suggest that you contact your medical team or your doctor before you pursue any other treatments or programs. And so with that, then I would like to introduce Rick Davis, who is the founder of ASnCan. And Rick, over to you.
Good evening, everybody, and good evening, Dr. Punnen. Welcome to ASnCan, especially welcome to our active surveillance, our weekly active surveillance group. We do something different to a lot of groups, which is we split our education and our support. So the whole of this session is going to be dedicated to you and what you tell us and the questions that arise therefrom. We've been around, just for your edification, we've been around since 2010. We've been running virtual chats like this since 2015, long before anybody outside the medical community thought about COVID. And we are pretty well positioned in this space. And delighted to welcome you today. And with that, I will pass it over to Howard Walensky to introduce you and the session.
Okay, thanks, Rick. Okay, a little bit of background on our speaker tonight. Dr. Punnen is co-chairman of the Genitourinary Site Disease Group at the Sylvester Comprehensive Cancer Center, University of Miami, Miller School of Medicine. You might ask them to shorten that sometime.
Yeah.
His talk is entitled The Current State of Active Surveillance and How Active It Needs to Be. And, you know, he chose that title, so he knows what he's up to. He will be covering, among other things, the changing role of PSA testing, the growing role of MRIs and biomarkers. I think he'll be explaining to us the different flavors of PSA, including total PSA versus free PSA. Dr. Punnen is a Canadian citizen. He trained at some of the hotspots for active surveillance. He had his residency up at University of Toronto with Dr. Klotz, and he had his Uro-Oncology Fellowship with Peter Carroll at the University of California, San Francisco. He received his MD from Queen's University in Kingston, Ontario. He is assistant editor of the prostate section of the Journal of Urology. So I think he's found the right place, and I'll just turn it over to him.
Great. Thank you, Howard, and thank you, Rick and Joe, for the invitation. It's nice that you guys are doing it, and you definitely have a worldly group. I'm seeing, you know, Bill from my home country in Ontario or Canada, then New Mexico, and Govinda from Cochin, India, which is from where my parents are from. So it's great to be here and seeing all these different groups represented. So as Howard mentioned, my talk is going to be on active surveillance, and I'm glad you guys do separate, your areas the way you do when you're doing these talks, because sometimes, I've been in many situations where I get asked to give a talk on prostate cancer. And as you guys know, that's a very expansive topic, and it's very, difficult to fit that into kind of a half an hour to an hour talk. But something on surveillance, and mainly what I wanted to concentrate on today is kind of how surveillance has changed and some of the newer markers that have come in. Now, there are certain things I may not speak to. There's a lot of new markers that are being used today in the detection space that have been somewhat played with in the surveillance space. And while it's not part of my talk, I'm happy to speak on any of them. And I'm going to talk a little bit about the role of PSA, mainly in terms of how we use it as follow-up. I will speak to other forms of PSA in terms of density, free to total, things like that to a certain element. But you'll see that the majority of my talk is really going to be focused on some of the newer markers that are coming to play, and how we're using them in terms of really deciding how active a surveillance process needs to be and when you really start on your surveillance. So you guys have probably heard this saying before, just based on the many esteemed speakers you have had here. But the godfather of uro-oncology is this person, Willett Whitmore from Memorial Sloan Kettering. And while most people will attribute active surveillance of prostate cancer to Lori Klotz, it really started with an idea that Dr. Whitmore had, where he was surveying a few guys with prostate cancer, and not guys that were doing watchful waiting. These were truly guys who had low risk disease, very healthy, but he just kind of had felt that this is not something that they need to go through the radicalness of the treatments at that time. And he kind of coined that saying as cure necessary when it's possible and possible when necessary. And I think when we talk about prostate cancer, this could not be a better summary, because we are often, lumping prostate cancer and many times with all kinds of other cancers that, that C word, and it's taken many, many decades to kind of come to at least closer understanding of what we're dealing with when it comes to prostate cancer and what the majority of cancers we see. So, I'm a big believer in evidence, and I think, in prostate compared to, let's say, breast cancer, we're far behind in terms of the evidence that we have that's backing our field. We have a limited number of randomized trials available to us to kind of make these decisions, but these are two big studies that were done that I think really support active surveillance. So on the left here, you're seeing a study called the PIVOT trial, which is done out of the VA health system. And what they did is they randomized men to either having pure observation, so no watchful, no PSAs, no biopsies, nothing like that, versus surgery. And what you can see is when you looked at each of the guys in the group and the risk of dying of prostate cancer out to almost 20 years, it was pretty much the same. You didn't see a difference between those that went to surgery versus those that were observed. Now, when you break them down into the individual groups, low risk, intermediate risk, high risk, you do start to see differences to certain extents. But in the low risk, you really saw no difference, suggesting that surgery, was comparable to active surveillance. You didn't see more death in the surveillance arm. This was the PROTECT trial, was more recently done in the UK, randomizing guys to surgery, radiotherapy, and active monitoring. And I'd say about 80% of the patients in this population were low risk, so more of guys you could survey. And at 10 years, you didn't see any difference in prostate-specific survival. So obviously, we want to see what happens as this data matures and gets out to 20 years. But very good evidence to suggest that from a hard endpoint of am I going to die of prostate cancer, it doesn't seem like you're going to have much of a difference in that, whether you watch it or whether you treat it actively. Now, obviously, there's a lot more that goes into that in terms of determining someone's risk, but in general, we're seeing that active surveillance does pretty well. And this is a slide actually from Dr. Klotz, where he was just showing kind of uptake around the world. You're seeing it in Australia, you're seeing it in Sweden, Canada, different registries. This is Michigan, New Hampshire, but you're seeing an increase in active surveillance globally in all risk levels, very low risk, intermediate risk. So this is really catching on. And you can see for the most point, most guys that go on surveillance, it doesn't mean that they're never going to need treatment. And I think that's an important thing to kind of realize when you're discussing active surveillance with patients, because many people will come in and this idea of, hey, I'm not going to treat this cancer that's inside me kind of is a little bit anxiety provoking. And so many times you just got to realize that surveillance is not always about treatment versus no treatment. It can really be about the timing of treatment, because many men will go on to be needing treatment, but at least you're letting kind of nature take its course, where many times we're making a decision today in prostate cancer for something that's never going to really be coming into effect until 10 years later. Surveillance is a way of naturally seeing what that cancer is going to do. So you can see if it's going to be progressing or starting to change. And usually then when you're starting to see those changes, you haven't really compromised your outcomes in terms of that. So when you look on average, it appears that about 30 to 50% of men around 3 years will go on and progress. And most of these guys, when they get treated, will do just as well as if they got treated right away. There's a small handful that may have a bad outcome, and it's not because their cancers progressed too quickly or we didn't see the changes quickly enough. It's usually that they had something worse to begin with that we just never knew, and we wouldn't have watched them if that was the case. And that's that whole concept of classification. And I think we're seeing less of that now, mainly because of things like MRI. So some of the things we're really going to try and touch on a little bit here is who is the right patient for surveillance, who is the wrong patient, what's the right type of follow-up, and how do people do it? And this is very variable. And what are the triggers kind of for intervention in terms of surveillance? So in the past, traditionally, surveillance has really been reserved for men with very low volumes of low-risk tumor. These are kind of the top 7, institutions that have done a lot of history with active surveillance, and these were the criteria that they used to use in terms of enrolling patients. And you can see here that they're pretty stringent. I mean, most of these criteria only allow men with low risk. A lot of them will only permit men with 1 or 2 cores positive, very minimal amount of cancer in the core. And I think the reason for this is because a lot of these criteria were formed in a period where we were doing just random template biopsies of the prostate. So there was a big concern about undersampling the gland when you do those biopsies, and therefore maybe underestimating the extent of tumor. So you wanted to be much more stringent in your criteria when you're selecting men. But I think over the years, as we've become much more comfortable with surveillance, we've got more long-term data suggesting that it's safe. And as I mentioned with MRI, we've become a little bit more willing to expand these criteria. And I think a big role player here is the role of MRI, even in the diagnostic space. These are 3 articles, all within the last 5 years or so, published in the New England Journal of Medicine, all speaking to the benefits of MRI over a standard biopsy. So, most places, I think, and I'm curious to hear what your experiences are, because they're all coming from different parts of the world here too. But a lot of places, at least in the US, are moving to a point where they're getting an MRI now before a biopsy, and that MRI has lots of impacts in terms of who's even eligible for surveillance per se. So for example, and this is something that we have to be careful about, because when we look at things and new technology that comes into the field, we often think about what it's benefiting us and how it's making something better. And we may be a little less likely to see some of the potential downsides of it. So this was a study we did looking at men who were eligible for surveillance based on these more stringent criteria, these older criteria. And we had about 100 men that we looked at. And so on their template biopsies, the 12-core biopsy, no MRI, this is the number of men that were eligible for surveillance based on each criteria. Now, after that, these were guys that actually did have MR-guided biopsies in our Fusion biopsy database. And when we added in the MRI or the MRI targeted cores, we could see that there was anywhere from about 6.3 to as high as 33% of these men that were eliminated just because of the MRI targeted cores. Now, some of these men, I would say, did have, maybe a more significant tumor that the MRI helped find, and they probably were appropriately removed from surveillance. But I would say the majority of these men were having tumors that probably got over-selected. So, you're going into an area where you're more likely to hit something and you're over-sampling, and now your biopsy looks like it's a lot worse than it truly was because you're just seeing more low-risk cores because the number of lesions you took. And when you have some of these criteria that don't allow any more than 2 cores to be positive, it's very easy that you could no longer meet the criteria because one of these MR-guided biopsies found an extra core of cancer. And so I think this is something that we have to be a little bit careful of today. I mean, I think we know from a very number of studies now that MRI is more likely to do a better job finding the cancer in the prostate. It's not impossible that you may see 90 to 100% of a core that has cancer in it. And while that would never be acceptable based on the old criteria, we really have to ask ourselves how well these old criteria work in today's era of MR-guided biopsy. Because if we see a little bit of 4 or we're seeing a higher volume of Gleason 6 in the core. Well, a lot of these patients, let's say the template biopsies were minimal and surveillance eligible, those patients haven't changed, and we've been watching them for years and they've done well. So the fact that we're, finding more cancer is just that our technology is getting better, but the patients are staying the same. So we have to be careful not to exclude a lot of guys who have traditionally done very well on surveillance, because we're just doing a better job finding what's really going on in the prostate. And we have seen that happen. So there's been a lot of people talking about, the benefits of MRI, but there's definitely a sense there that there could be a place where MRI leads to overtreatment if we're not careful how we use it. So just one point I wanted to kind of bring home there. Now, in terms of, when you're diagnosed now and what your options are, and let's say after the biopsy. Sorry, any questions or no? So this is just NCCN criteria you can kind of see here, and this is just looking at the different risk groups. So when, anytime you're diagnosed with the cancer, prostate cancer, you're going to be put into a risk group, and that's going to be based on what was the Gleason grade that they found in the biopsy, how many cores were positive, what was the PSA, what did the rectal exam feel like, did it look like anything was getting out of the prostate or not? And all of that will kind of help determine whether you're a very low risk person, a low risk person, or an intermediate. And you can see here, very low risk is as good as it gets. It means you were, 1 or 2 cores were positive. You basically, your PSA is under 10, no core with more than 50% of cancer in it, only Gleason 6. So very minimal cancer. And you can see here for men like that, the preferred method is active surveillance. These guys really should be watched because it's likely that their cancers will never, ever go on and hurt them. But obviously, surgery and radiation are still possibilities. Potentials for those that are nervous about watching or wanting to be treated. And you're seeing similar things in the low risk. Now, I know Howard's going to ask on this and we can definitely touch on it. The most recent guidelines did talk about, you can see in very low risk, you have preferred, and it was like this in before for a low risk as well. And now you're seeing it moved, and it's not really given the preferred, even though it is at the top. But all the other options are still available to this. And my thought is, that low risk is a little bit more of a heterogeneous. That does include guys with up to, there's no number of cores that you can be positive. So there's many men in this low risk group that would get treated at most in academic institutions with their very, very high volume that would fall into that low risk. So I think personally that's probably why they did that. But it doesn't necessarily mean that active surveillance would not be the preferred option for most men that are low risk. And so, it may not have gotten the preferred category there, but I think it still is the preferred option. And then even in the favorable intermediate risk, you're seeing as an option for guys that kind of have a little bit of Gleason 3+4, a little more aggressive cancer than your typical 3+3. Now, one thing I wanted to kind of draw everyone's attention to is if you look at it, in terms of the workup, whether you're very low risk, all the way through, it's kind of the same, so you can see, consider confirmatory biopsy with or without MRI, consider molecular tumor analysis, PSAs no more than every 6 months, DREs no more than every 12 months, and biopsies, no more than every 12 months. Now, to some degree, this is, trying to provide a strategy that's going to be able to be applicable to any real man. But it's pretty vague as well, because there's a lot of room for variability in terms of how you're going to do that monitoring. So there's some places that will do a PSA every 3 months, others will do it every 6 months. I think most studies that have actually tried to compare have not seen significant differences between the two. So I think we do every 6 months, and I think that's reasonable. Howard mentioned a lot on free to total, ISO PSA, some of the other derivatives that you can have out there. I'll be honest, I don't use them a lot. I think the one that is helpful and has always kind of been helpful is PSA density, where you take the PSA and you divide it by the prostate size. I think that does allow you to adjust, let's say for BPH, which is always the main, confounder, guys that have a big prostate. So it's not, that their cancer is pushing their PSA, it's just the big prostate. And so doing a PSA density is probably the one thing that helps your PSA become more powerful, because it's not going to be as impacted by issues like BPH, and it'll be a little bit more of a truer indication potentially of the cancer. So I do think that has some value, mainly in selecting patients. But outside of that, I don't put much faith on PSA itself. Even PSA velocity, when you start to see PSAs going up, I don't tend to panic that much. Most of these guys have been getting more serial biopsies, and so that may play an impact, some prostatitis, things like that. And so I traditionally find that guys on surveillance will have more of a rise in their PSA, but it'll never prompt me to treatment. You know, there's been some algorithms to say if your PSA velocity is over 2 a year, you know, you should be treated. I don't know that we do that. It may make you do a biopsy earlier, but not necessarily treatment. So, you know, it does speak to the fact that, you know, we are seeing an expansion of these eligibility criteria. I think more men are providers as well are comfortable following higher volumes of Gleason 6 disease. I think the area where there's still a lot of controversy is in the Gleason 3+4s, the intermediate risk cancers. You know, this was a study by Dr. Klotz looking at the Toronto cohort, which is probably the oldest cohort we have. And they did find when they looked at the 3+4s versus 3+3s, there was a higher risk of metastasis. So I think while we've gotten a lot more comfortable following 3+3s and are willing to do more cores positive than we typically did in the past, there's still a lot of uncertainty around how we treat 3+4s. And I think you see a lot of variability around the country in terms of people that will get counseled more towards surgery versus counseled more towards surveillance. One of the things that we do at our institution, and I would like to say that most places are starting to do now, because I think it has probably one of the greatest impacts on helping what to do with these 3+4s, is actually quantifying the amount of 4. So, you know, this new concept of grade groups, I don't know if you guys I've heard more about them or using it now, but I think it's going to be something that we're going to use much more than the Gleason grades, just because it just makes sense. It's more easier to discuss with patients. And I think when you think about the grouping of patients that you want to see, it makes more sense. I mean, Gleason 7 is such a heterogeneous group, and the 3+4s behave very different than the 4+3s. So splitting them up into 2 groups, which is what the grade group does, you would call grade group 2 as a Gleason 3+4 and grade group 3 as a Gleason 4+3. And I think that cuts down a lot of the heterogeneity that's in that Gleason 7 space. Because that 3+4 is that favorable intermediate risk patient that we may be willing to follow. And what really makes a decision as to whether you're going to follow them or not really may be how much 4 is there. Now, a lot of reports that we get back will have, 3+4 was found in the biopsy and it was in 40% of the tissue. Great. But does that tell me whether most of that was 3? Was that 4 component only 5%, or was it 49%? I know if it's above 50%, it's a 4+3. But I don't know whether this is a little bit of 4 or a lot. And if you can see here, the percentage of 4 here, and this guy is only 5%. So to me, he's going to behave a lot more like a 3+3, and I may feel much more comfortable following that person. But let's say this was more like 45%. Then I would think he's maybe going to behave much more like a 4+3, and I would believe that there's probably a lot more 4 there than I hit on the biopsy, and it may change how I do. So just quantifying the amount of 4 that's in the pathology, I think, is a very important thing, especially when you're considering, surveillance on these guys that are in the favorable intermediate, because you're basing your decision on the 4. So you want to know how much is there. So in terms of the workup for surveillance and where some of the, newer tests and things like that come in. So this kind of just shows down what are the criteria for you to be considered very low risk, as mentioned, T1C, grade group 1, so only Gleason 6, PSA less than 10, and no more than 3 cores positive. The low, you don't really have a number of cores. So you could have a guy that has, let's say, 9 cores positive here, and around the country, I think most of those guys would go for treatment, just because of the concern that there's going to be a 3+4 somewhere in there. And that, I think, is what played a role maybe in terms of removing it as the preferred, because you don't want to necessarily say that that guy should have had a preferred option of active surveillance, because that may not be the best thing that's for that person, especially if he's young and he's got 9 out of 12 cores positive with a high volume of Gleason 6 that would still fall into low risk. So that's my take on it. And then you see the intermediate risk group. And I think, while we're seeing the recommendations, consider and not, and it's pretty much the same in each of these. I do think there's a difference in these men, and that difference could probably play a role in terms of how intense their surveillance needs to be. I think guys very low risk probably don't need much in the way of their risk stratification, and their monitoring could probably be less intense, whereas those guys in their intermediate group probably need a lot more at the initial risk stratification and need to be followed more closely. I think that is something that we need to be moving towards, because there is a lot of burdens to active surveillance monitoring, the repeat biopsy, things like that. And I don't think we pay enough attention to that. So especially a lot of these guys with very low risk, we do a huge disservice to them to do a biopsy every year or every 2 years, when they may be able to get away much more without a biopsy and rely more on things like MRI. So I'll just stop for a quick second there to see if anyone had any questions before I kind of go into the MRI and the genomic marker space. Okay, great. So MRI, I think, is, in my view, a game changer in this whole space of prostate cancer, from detection to, surveillance to focal therapy and even surgery. It's been the best tool that we currently have for localizing prostate cancer in the prostate. And it's not just, your T2 weighted images. There's some functional components as well. So when they do a multi-parametric MRI, they're basically doing an anatomic sequence like the T2, but rather than just doing something where you're going to see a dark area, you actually do look at contrast uptake, and you look at this area thing called restricted diffusion or diffusion weighted imaging, which is really a sense of how the water molecules travel through cells. So it tells you how thick a tissue is. And typically cancer is going to look darker in the area on the MRI. You'll see more contrast where the contrast enhancement is, and it looks darker on this DWI, suggesting more thicker tissue. And the way I think it helps the most is, I talked about the concerns of MRI and how you can easily oversample a tumor, and that happens more than not. But where the benefit of the MRI lies is an example of this guy here, for example. In a typical biopsy, you're only going to really sample the back of the prostate. If the rectum's down here, you're getting this area right here. But you can see that this gentleman here has a lesion in the front of his prostate that, you're not necessarily going to hit unless you push the needle all the way through. And unless you knew there's something in that area, you're not going to push that needle all the way through like that. So the MRI kind of at least tells you whether there's something more that could be going on that you didn't sample, that you should know about. And I think when you look at the criteria we used to have in the random sampling area, where we had a lot more uncertainty about the true extent of cancer, big reason why we've been able to expand our criteria and offer surveillance, I think, to more men that have higher volumes or higher grades of cancers, because with an MRI and a targeted biopsy, we are much more confident about the true extent of cancer in the prostate. There's less upgrade when you go from biopsy to surgery when you have an MRI involved. So I think that has played a role in terms of eliminating guys that may be truly likely to progress. And this was a study that kind of helped bring that home. This was from the University of Toronto. Assume Hayder and Laurie Klotz did this one together, and they looked at about just over 200 men that were randomized after getting diagnosed with prostate cancer, just Gleason 6, they go on surveillance, and then they get randomized to getting an MRI and then MR-guided biopsy, or just a regular template biopsy. And you can see that at the beginning of the trial, they only saw about 20% of people progress or reclassify, so no difference between the two arms. However, in the 2-year mark, you could see there was a lot less people that reclassified after MRI. So a lot less people in the MRI group that actually went on to progress. So in the end, they found that the MRI group had less progression, and I think that's probably because you found them earlier on. So that was level 1 evidence. This was a randomized trial, and the first one really that showed a benefit for MRI, not right away, but after about 2 years. So I think that does push more evidence behind MRI, and you're seeing a lot of guidelines committees that do that now. So Cancer Care Ontario, there's always been restrictions to MRI there, but they do recommend an MRI when you're getting any discordance between what you're seeing in the pathology and, let's say, the PSA or anything like that. So for example, you do a biopsy and you're not seeing much cancer there, but the guy's PSA is going up drastically. That's when the MRI is going to be indicated to see if there's anything going on. ASCO and NCCN, they kind of talk about it more as a consider, just because access is still an issue. But then if you look at the NICE guidelines, which is from the UK, where they've really kind of been doing MRI for a while, everyone gets it on enrollment. So they really consider it to be a major part of their surveillance programs, and everyone is getting one. So you can see some variability a little bit in terms of how people are using MRI, but I do think it has some value. Now, I think the greatest value is mainly in the very beginning parts, where you're kind of trying to weed out those guys that may not, like I said, the guys that truly do bad on surveillance are ones that had something really worse there that you didn't know about. And I think MRI really helps you eliminate a lot of those guys, at least. You just have to be careful how you use it. Now, in terms of monitoring afterwards, I think there's a little less evidence there. You can see this is data from the NCI, Peter Pinto's group, and you can see at 2 years when they compared what you found on targeted biopsy to a random biopsy, there was a difference. You found a lot more on the targeted biopsy. So that suggested that the MRI was helping. This is an MRI targeted biopsy. But at 4 years, while there was still a difference, it wasn't significant anymore. And at 6 years, even less of a difference. So this could be just smaller numbers that got out to 4 years and 6 years, or it could be that a lot of those bad actors have always been weeded out now in the first initial samples. And what you have left, MRI is not really able to tell the difference between, because you're catching very little progression. And that could be the case. And so that really, brings the question of whether, MRI will be helpful in terms of monitoring. Can it truly replace a biopsy? And currently, I think we feel it can't. Most guys will say that we should still do a biopsy every 3 to 5 years, even if the MRI looks okay, because the MRI could miss progression. I think there's truth to that. That is what we do right now. But I think where the future will change this is in terms of a lot of the quantitative imaging, AI. At the University of Miami, we do a lot of work in this space. I work with a physicist right now who's built this tool that combines the contrast enhancement and there's restricted diffusion components of the MRI and creates a heat map. And basically, it just reads the MRI on a pixel by pixel level and applies this kind of heat map completely independent to any radiology read. And it identifies the transitional zone of the prostate and the peripheral zone on its own. And realizing that there's differences in cancer detection within those zones, it kind of applies different thresholds to kind of determine what's considered significant or not. And so we've actually, this was built using radical prostatectomy specimens, men that had cancer in their prostate that went to surgery. And so we were able to look at the MRI and look at their radical prostatectomy and match it up. And you can see actually there's a couple areas, where there was a tumor here in the top left or top right, and you can see that the MRI actually did a pretty good job catching it. And while that was caught, by the radiologist here, there's other ones that the radiologist has not necessarily found, and then the system has. And we're actually recently being funded by the NCI to actually look at this now in patients who are going for prostate cancer evaluation. So just like I said before, a lot of guys are getting MRIs before they go to a biopsy for diagnosis. We're doing a trial now where on top of that MRI, we'll have the AI read it as well and see if there's anything else to see if the AI can kind of make the uncertainty in MRI a little less. So this is an example here of a patient that went to radical prostatectomy, and he had this lesion that was found by the radiologist, 4+3, and you can see that the HRS did find it, and so did the radiologist, but there was another lesion in here, a 3+4, that was not found by the radiologist. Now, in this patient that went to surgery, it may not have made a difference, but if we were considering focal therapy, then not knowing about this would have had some implications, in terms of that patient definitely recurring. So I think tools like this and you can see here that unlike the radiologist that'll kind of draw like an area, here you're able to get a little more granular detail about what's looking concerning in there. So I think tools like this are going to be what help us improve the usability and utility of MRI and monitoring. And while right now an MRI can delay a biopsy, so if your MRI looks fine, maybe in between biopsies you can push the biopsy off, it won't replace it. But maybe with something like this, we'll get to a point where we can at least come closer to replacing it or feel more confident that there isn't a change if we're not seeing any of these things change in a more quantitative manner. This is just another example. I mentioned that we have a trial for guys that are on active surveillance, and we're looking now back at the HRS on them. And we can see that, this is a person, for example, this is when they first came in. This was, the radiologist had mentioned something here, and then they caught something here. But you could see that this is when they first came, there was a lesion right here. And then at 1 year, you could clearly see that this was growing. And it was only at 3 years when we actually found it and biopsied this person. But we would have known about it much earlier on in the process. So this is what I mean when I say, could this have helped us in monitoring? Because from this at baseline to this in 1 year, we didn't notice anything going on here. But this would have given that hotspot. And that may have made us, concentrating on this area a lot more on the biopsy had we known if something was going on there. So just my kind of take on MRI and the role it plays, getting closer to summing up here. But just a little bit on genomic markers. I'm sure you guys have heard about these markers. There's these three major companies that are in play. They definitely have played a splash in terms of active surveillance, because a lot of people are using the test to kind of determine what the biology of their tumor looks like. And so, the goal of this was really to try and say, let me look at the genetics of the actual tumor itself and some of the genes that are in there and match it up to other people that had similar genetics and what their outcomes were like. And so there's a few different things they had to overcome. One, companies had to overcome the fact that you're getting very little tissue. Biopsy doesn't sample much. And then there's a lot of heterogeneity in that tissue. So, you have a 3+4 over here, maybe a 4+3 over here. What kind of signals are you going to get? Are you going to look for signals that are the same in between them? And how it deals with that kind of heterogeneity. So those are some of the challenges these companies had to come through, and where I can't say whether they succeeded or not in that, but we do know that the genetic information we get back from these tests are independent predictors. So even when you have the Gleason, the stage, MRI, all that, this information on its own does tell us something about the risk of recurrence or the risk of having an adverse effect. And this information is different than all the other information we can sometimes get. So this was a study by Matt Cooperberg at UCSF. And what they looked at is all these men that look clinically low risk. So they all appear to be the same clinically. But when you profile them, you can see a very big difference in their genomic risk. I mean, the top 20% here are in the high genomic risk area. Now, what does that mean? Does that mean they're all going to progress or they're all going to do bad on surveillance? That's the problem. Nobody really knows. We don't have the data on all of these patients. So it's hard to say what these high risk means, especially when they're discordant to all the other clinical information. But I think that's what's missing in some of these tests, is that follow-up. And this slide is just looking at the regional adoption of this. I mean, you're seeing on average about 10%, utilization of these tests. So it's not something, if they were really the holy grail, you'd expect to be seeing them much, much more. And while they do get used, majority of where it's used is places that have some sort of financial incentive or some other reason to use it. A lot of academic places are not, outside of just research. So just something to kind of keep in mind. There's a couple large active surveillance cohorts that have looked at this. So the Canary Paso cohort, which is a one led by Dan Lin at Seattle, and they looked at the genomic health test, GPS, and they found it did not help in predicting upgrade. There was another one looking at the music collaboration here in Michigan, and you could see these are the guys that came Decipher high risk. These are the guys that were Decipher intermediate and low. And on this y-axis here is basically your time to treatment or time on surveillance. And so you can see basically what it's saying is these guys that were high Decipher did not stay on surveillance as much. They were much quicker to get treated compared to these guys that were Decipher intermediate or low. But it's very likely that the Decipher itself is what was prompting the treatment, because when you actually look at the biopsy reclassification rate in this group versus that group, it was the same. So it wasn't that these guys were actually progressing, but they were more likely to be treated, maybe just because of the Decipher high. Now, whether that was the right thing or not, we're not really going to know. But the group of Michigan is coming out with a randomized trial. Todd Morgan is going to be leading that, and I think this will be very helpful to know what are the benefits of this in this group. So, we have a similar study going on at the University of Miami. It's close to enrollment now, but it just, finished about 5 years. Guys, basically, that are coming in, we allow anyone from very low risk to intermediate risk. So anywhere from like 1 core of Gleason 6 to 2 cores of 3+4 can go on. They have an MRI and they have a guided biopsy at baseline, and then they have an MRI and a guided biopsy at baseline every year after that. Now, do I think they need the biopsy every year? No, they definitely do not. Some of them may, but most do not. I think it was designed that way mainly just because we wanted to get a good sense of how well the MRI could track the actual biopsy and the cancer progression. And if we spaced it out too much, we wouldn't really know that. But the other thing we do is every core that's positive, we send it off to Decipher for genetic testing. And we collect blood and urine, which we're looking at various markers, genomic markers, sending things off to different companies as well, to kind of see if we can get kind of a liquid biopsy. They could tell us the tissue information that we're getting. So there's a lot of information we get on this. We don't necessarily, for example, the tissue signatures we send off, we don't even look at them. It's not like we're making decisions on them. It's a lot of information we're going back and getting. But in the end, what I'll be able to do when this trial is fully done is to say, hey, if I had a guy that was low risk versus a guy that was high risk in that signature, did I see an change in what their cancer did without us intervening in any way? I can say the same question for MRI. When you were negative MRI versus a positive MRI, did you see a difference? And did MRI actually catch this cancer as it was progressing, or did the quantitative imaging, so my future is what I hope prostate cancer to be is, you go and you have an MRI done, you may be having a blood or urine test to get all this genetic testing done, and you can see we're collecting all of this information on patients every single year as it gets done. So in the future, I hope we won't need to rely so much on biopsies. We would have done a much better job doing risk stratification earlier on, and then using yearly MRIs and liquid biopsies and some sort of cloud-based kind of approach that brings all this stuff together. You can kind of feed it back into some system that can actually monitor to some sense what your cancer is actually doing. Now, is this a little bit too crazy and we'll never get there? A lot of people have told me not in our lifetime, but I don't think we're that far from that. When you think about the amount of information we get out of an MRI, and if we could train that to monitor these cancers better, and we find a more suitable liquid biopsy marker that can tell us what the tissue is actually doing, which I don't think we're that far from either, then these kind of things I don't think are impossible. So the last thing I was going to just comment is just on the activity of the surveillance protocol. So I think, for me, I get asked a lot by my residents, what's the best active surveillance protocol? What's an ideal surveillance protocol for someone? And I don't think there's any one protocol that's going to fit everybody. I think there's a handful of guys that really need to be minimized, and their burden should be de-escalated significantly because their cancer is very unlikely to ever hurt them. There's another group of guys that kind of fall in the middle, and there's others that really do need to be pretty intense follow-up. So for example, this guy, 64-year-old male, one core of Gleason 6, less than 5%, a very incidental finding. His MRI was negative. I believe in confirmatory biopsies on everybody because you really do want to eliminate the likelihood of undersampling something. So let's say this guy comes on confirmatory biopsy is negative. This kind of person, I think you could get away with doing a biopsy almost every 5 years even, and minimizing the MRI to, we do it every year, but every 1 or 2 years. He really needs less intense follow-up for the most part, because I think, the bigger risk is the biopsy risk and everything else. The cancer that he's got is very unlikely to progress with these type of features. Now, this person here, let's say, 64-year-old, 2 cores were positive. He has a little more core, 20, 30% of the core being positive, something on the MRI. You do a confirmatory biopsy, you're still seeing some cancer, 40, 50% kind of thing there. This is the kind of guy that I think is the average active surveillance patient, probably going to need, PSAs every 6 months, MRI every year, and I would probably do a biopsy every 2 or 3 years just to make sure things aren't changing. Now, if you take the same kind of guy and you add some of that 3+4, we do know those 3+4s can move quicker. Potentially he has got an MRI that's showing something suspicious as well, and his confirmatory biopsy shows that there's 3+4. These are the guys you could talk to about treatment. They should at least know their options. They should know that if they're watching this, their risk of progression is greater than if they were just a 3+3. And that's the type of person that may need to do biopsies more frequently just because, they're almost at that cutoff where you would intervene at that point anyway. So I don't think there's any one particular surveillance protocol that fits everybody's needs. I think you really have to change it to the type of person, the person you're dealing with and the type of cancer that they have. So to conclude, compared to where we were, let's say 10, 15 years ago, criteria are definitely selecting. I think part of the changing and expanding, part of that is our comfort with surveillance, seeing long-term data showing that it's safe. Part of it is better tools like MRI that have helped us reduce the uncertainty of what's going on in the prostate. And I think that all helps to kind of minimizing biopsies. I think in the past where we would say a guy goes on active surveillance, gets a biopsy every year, I don't think that's happening anywhere really now. I mean, most places are trying to minimize the number of biopsies that they do. Again, I mentioned active surveillance or MRI definitely plays a role in the selection. The monitoring is a little less clear, and I think these markers will definitely be helpful. But to what extent they're helpful and how we use the information, I think there's a lot more information yet to be learned. So with that, I will stop and happy to take any questions.
Okay, well, Sanoj, thank you very much for the very clear and useful, I think, presentation. I'm going to ask a few of my own questions, and I don't know if some of the other moderators want to dive into the questions that were submitted, but you had mentioned high volume uh, Gleason 6, and this has been a subject that's increasingly come up in this group. Like we had Dr. Egner a couple months ago, kind of suggesting that it's not very common, but it is suitable for surveillance. Meanwhile, Dr. Catalona at Northwestern University came out with a large study last month uh, in the Journal of Urology. And one of his major points in there was that Gleason, high volume Gleason 6 resembles more advanced cancers in a lot of ways and maybe should be treated accordingly. So is there a lot of debate on this? I think you may have shown your hand, but maybe you can explain it in a little more detail.
Yeah, I mean, I think there is to some degree more debate. I think the reason, so if we had a ability to say that someone was, let me start off a few things. Gleason 6 itself, I think we all feel very comfortable with. And when you look at Gleason 6, the hallmarks of Gleason 6 compared to a Gleason 4, a lot of the molecular things that happen at a level that make a cancer progress or, invade or do something, metastasize, Gleason 6 doesn't appear to have those. So just biologically, it's a different entity than the Gleason 4 and pattern 5s and things like that. The main concern, and if we knew that, let's say there's going to be Gleason 6s that are in the prostate and they stay Gleason 6s, then I don't think there would be much controversy about not treating them. The concern really is more about if you have a lot of Gleason 6, you're probably likely missing some Gleason 3+4 in the prostate, and that's why we go looking for it. And that's changing a little bit now too, because in the past, I think, we would always associate Gleason 3+4 as the trigger. If they have that, we should do something. So in our mind, our thinking process is, well, even if we're not seeing on the biopsy, if they're likely to have it in the prostate, then we should do it as well. But even if a person was to die with a Gleason 3+4 that's in their prostate, that's not going to be a loss. I mean, it's not like that's going to be the 3+4 is the thing that's going to make it metastasize. So I think we have to take each of those situations with a grain of salt and kind of look at it, because what do you call high volume? If you're saying something is, let's say, more than 4 cores is high volume, well, there are some places that do a targeted biopsy and they take 6 cores right out of the area, and if that's a cancer, you're definitely going to have 6 cores positive right there. And so if you did a 12-core template, that's a 1/3 of your biopsies that are now positive, but you had only had one area that was really a Gleason 6, right? So I think you have to look at each of those things kind of separately. I think a person that has high volume Gleason 6 is a person that doesn't necessarily need to be treated, but the likelihood that they are going to progress is more. So you may want to counsel them towards that. And then again, the importance of having that confirmatory biopsy to make sure you didn't miss anything and to catch progression earlier on, because that person is more likely to progress than, let's say, someone with 1 or 2 cores of Gleason 6.
Okay. Now there's a mandatory question that we ask every time now. Where do you stand with transperineal versus transrectal
Yeah.
biopsies?
So I've been doing transperineal probably for about 4 to 5 years already. And I feel like I've only been increasing the number that we do. So yeah, so there's a few things. One, I think the major benefit obviously is reducing the infections. We didn't really have a very bad risk of prostate biopsy infection in our cohort. We always give some IM penicillin when they come, and we covered with Cipro. So we didn't have a big risk of sepsis post biopsy from our group. But I obviously remove, when you do have a guy that goes through that, it's changing for their life, obviously, and it's a lot to go through. So eliminating it, or being able to tell that person, hey, we don't need to even really take antibiotics, we just give you a shot of penicillin in the OR, and they're not on the Cipro for 3 days, I think there's a lot of benefits to that. Anecdotally, I've also seen better detection. I think some of the areas like the anterior part of the gland, the apex of the prostate, that are maybe a little more difficult to hit in the transrectal and can be more painful, they're easier to do transperineal. Now, the challenge, I think, is the anesthesia. Where transrectal, it was easier to get the anesthesia down and not an issue. I'm still doing a lot of my guys with some light sedation just because I feel the block is still not good enough that they do feel it. But again, I think I'm still kind of, doing more and more of those transperineals. But I know a lot of people that do them in the office and they say they don't have a big problem, but I think it's also just expectations too. But I think we're going to see a switch where we see a lot more being done transperineal.
Okay, I'm going to switch over to Leaf, who asks, you talk about MRI. How about micro ultrasound? Dr. Klotz gave us a big plug for micro ultrasound last week. Where do you stand on that?
We just bought one, so maybe ask me in a year and I'll have much more personal experience on it. So here's one thing I will say. I have used it a few times and I think the resolution is phenomenal. I mean, you see so much in that ultrasound when it's high frequency like that, and pretty similar to what you'd get in an MRI. The studies suggest they're equivalent. And I think there's probably going to be some truth to that. I think like anything else, there's going to be some experience that goes into their learning curve, learning how to read the ultrasound. It's not so, to me, I learned how to read MRIs in my fellowship, so it was kind of just more natural. Whereas on the ultrasound, it's still hard to tell between a benign looking area and a malignant looking area. And they have a whole classification scheme that Klotz probably maybe brought up, starry night, different cheese pattern, things like that. you know, that's not intuitive to me. So I think that, getting some experience, learning, how to use it and what looks real, what doesn't look real is going to be a role there. But all the things that we see with MRI, we're going to see, we see false positives and negatives with MRI. I don't think we're not going to see that with this. What I think there's going to be a benefit to is also how we use them together. So if and I asked this question, let's say, for example, if we're trying to use the micro ultrasound as an MRI, the way Klotz would use it is, especially in Canada, I don't think you can get an MRI if you haven't had a biopsy before. So you get the micro ultrasound, you're doing a transrectal ultrasound to see if you have anything. And if you don't, then you don't do the biopsy. But most guys would say, I'd rather do an MRI than the transrectal ultrasound. And I don't know. So that's the one thing. Is it logistically from a workflow? Is that something that most guys would want to do versus an MRI? Now, where I think what'll actually come in is we're still going to be relying on MRI as our screening test. But when we go to do the biopsy, we may do more of them on this ultrasound, because by doing it right on the ultrasound and saying, hey, the MRI showed me something in the right apex, I'm seeing this starry night in the right apex, I'm more confident that that's what it's looking for. And rather than have that fusion of MRI and ultrasound and an error that it can bring in, you're now doing a image guided on one platform. So just the ultrasound. So there's no error of an incorrect fusion between two images. And I think that will make the biopsy more accurate. So that's how I think it's going to get rolled out.
Okay, well, we're going to switch directions here a little bit. Rick asks, well, he mentions that he's working with a guy who's a 3+3 in intraductal.
Mm-hmm.
There's always an exception, but why would we not standardly look for cribiform or intraductal in 3+3? And maybe you can tell us, what intraductal means.
Well, yeah, intraductal, I mean, not ductal, right? Just intraductal.
Right.
Yeah. So intraductal, I mean, so again, I don't know exactly how from a pathological standpoint, but it's kind of like a feature that they see that they've kind of said is similar to Gleason 6s, and they don't behave that different than 3+3. So I think it's just a subtype of 3+3 that you see. Cribiform, on the other hand, I mean, if you're seeing cribiform by definition, it's a 4 now. So that's probably why they don't call it in the 3s, is because if you see it, it's a 4.
I see. Okay, let's see here. Here's another one from Wayne. What are your thoughts on duration of ADT for men with Gleason 3+4 versus 4+3? And again, we're mainly active surveillance group, so maybe you can tell us what ADT is.
Sure. So ADT, androgen deprivation therapy, is the kind of the hormone medication that we do a lot with metastasis, but we use it a lot in patients undergoing radiation. So if you're low risk and you're going through radiation, you don't need any ADT or hormones. And for the most part, this is an injection that you can get every 3 to 6 months, but there's also oral pills you can take now as well. If you're intermediate risks, it's 4 to 6 months of hormones. And then if you're high risks, you're talking about more of like 18 months of hormones. So the guidelines would probably have said that they don't really differentiate between a 3+4 and a 4+3. And they would have originally said 6 months is what you need. And now they say the 4 months is equivalent to 6 months. What I would say I am seeing more and more people do, and here's the thing, right? What is the difference between 3+4 and 4+3? More often than not, it's biopsy sampling, not the patient, right? So if you were taking out that guy's prostate, of most 4+3s, they're going to be 3+4s. So we may be making a distinction that has more to do with the type of biopsy a person got or how lucky we were to hit something than their actual tumor parameters. And to that point, a lot more radiation oncologists now are getting these Decipher tests, one of the signatures I had mentioned, that they do use in the surveillance setting to decide on whether you treat someone or not treat someone. But they're also, it's not really necessarily a test just for that. I mean, it's a test to give you a sense of what the tumor biology is. So you can use it in many different areas. And one of them is, if you're going to be treated, what's the treatment intensification? So if it's low risk, they may say that guy doesn't need any hormones and we're just going to treat him like he was low risk, if he's low genomic risk. Where if he comes back high, they may actually give a guy that's intermediate a year, potentially, So I think these things are things that need to be validated, but there were definitely some studies showing that guys who had high genomic risk did much better with long-term ADT than short-term ADT. And that information is getting used a lot more by radiation oncologists now when they think about that duration.
Okay. Now, Lewis asks, how important is it to continue annual digital rectal exams after being diagnosed with low volume, low grade cancer?
Yeah, so I have to admit, I don't do many digital rectal exams now. I find that there's few scenarios where the information is going to be valuable to you. I think especially when you have guys that you're doing surveillance on who are probably getting more serial imaging, that at least once every 2 or 3 years, they probably do get a biopsy and you're going to do a digital at that time. Having a digital when you come in every 6 months for the PSA, I just don't think it tells you much. And a lot of times some of the nodules you may feel, and even though I've heard a lot of argument, well, what if I feel something? I only found this cancer because of a nodule. And there are lots of anecdotes out there where something like that happened, but there's a lot more times where a nodule led someone to do a biopsy that didn't find anything. So I just think we have much more sensitive tools nowadays than the finger. So I don't rely on it that much.
Yeah. Now, just to follow up on that, I've heard from some men that they find that, digital rectal exam painful or uncomfortable, and I think in certain subpopulations they see it as some sort of I don't know, homosexual activity or something. What kinds of issues do come up with it? Are people embarrassed about it, or is it painful for some men?
Uh, well, yeah, I think it can be painful for some men. I mean, I think you see different types of guys. There's some that want to avoid it at all costs. Most guys I don't think are like that. They know they may have a cancer, so they're following it. And I think if a guy is actually surveying a low risk cancer, he's probably more likely to want to hear that everything's okay. But I guess where I really kind of draw on it is, if you're surveying that cancer, there's not a single guideline that'll tell you that, the DRE is going to be the critical point of telling you whether that's progressing or not. So what it adds to your risk assessment, I think, is probably very minimal, and it's more of a dogma than anything else. Where I really get more concerned is in the prostate cancer evaluation space, because you do see guys that are wanting to avoid going to a doctor or wanting to avoid the screening because they just think of the DRE, and as a result may not get screening altogether. Um, and so there have been studies that have shown that men are less likely to go for prostate cancer screening because of things like DRE. And I don't think the DRE adds that much, and if it's bringing any burden, then I think we just have to reevaluate what we're getting out of it. So I personally would like to see it less emphasized in all of those things.
Now you did mention the change in the guidelines for the sort of lowered the standing for men with very low, well, for men with low risk prostate cancer. But in reality, do you think that this is going to have much of an impact? And by the way, what percentage? Okay, we have X number of men diagnosed with prostate cancer each year. So, what percentage of them are low risk, and what percentage are very low risk?
Hmm. It's hard to say. I actually don't know the answer to that question, but I would probably assume you'd see equal proportions of them, for the most part. A lot of it's going to depend on how they're getting diagnosed too, because if you're doing an MR guided biopsy, you're probably going to more likely, if there truly is something there, you're more likely to find a couple cores, which will make a guy low risk more than very low risk right off the bat. So I think, that is, to answer your first question of whether it's going to make a big difference, I really don't think it will. The NCCN guidelines are just they're guidelines, but it's not like people base everything that they do on it. I know that the main concern that people have had is that someone can now potentially justify offering a radical surgery or radiation, to somebody because it's listed as equivalent as active surveillance, But at the same time, I don't know that they weren't doing that before just because it said active surveillance was preferred. It's still at the top. It's still one of the major
Well,
options. Everybody knows.
Well, let me interrupt you on that. Is it at the
Yeah,
top alphabetically, or is it at the top preferentially? You know,
I don't know. I don't. That's a good question. I don't really know. But the, just the fact that many people didn't even notice it. I know it's created a huge Twitter storm and a lot of things like that. But do I think it's going to have a big impact on how people manage patients? No, I don't think so. I think at a lot of
well,
the main institutions where they've been doing a lot of surveillance, they're going to continue to follow low risk. I don't think that this guideline would change
I should mention I put in the chat box a link to an article I wrote about this controversy, and in January we're planning to have both sides
that.
represented in a debate late in January, but more about that later. But so okay, you don't see much to it. It's a tempest in a Twitter storm or something. Or
I think what they were, I mean, to me, the way I looked at it is, do I treat some guys with low risk tumors? Yeah, there are some guys. If I have the very young guys with high volume and they know they're likely going to be treated or progress in the future, you know, and I think many places, even at UCSF, I saw guys that were low risk that will get treated if they were high volume, you know. And so having a guideline that said preferred surveillance didn't change them from getting that because there is more heterogeneity in that low risk group than compared to the very low risk. Very low risk, I mean, you can't really find a reason as to why someone there would get treated. So it makes sense to say preferred, whereas in low risk, there's probably a small handful of guys that you could find consensus on treating them. And so I think it just makes it a little hard to say preferred because if you can find a group of guys that's, let's say you had a biopsy and 11 out of the 12 cores were Gleason 6, 100% in each core. Most places would say you should treat that guy, but that guy could be low risk, So to me, it was just trying to get rid of some of the heterogeneity, in that process. But I don't think it's going to change what people do. If you have a guy that was 3+3 and you would normally survey him, I don't think it's going to have guys that will change that to saying treatment just because it didn't say preferred this year. That's my thought. But
yeah, well, what is your thought about the status of focal therapy? Is it becoming more accepted, or are insurers paying for it?
yeah,
What is? What's
Yep,
going on with it?
insurers are definitely paying more for it. I think it is definitely becoming more accepted. More patients know about it, are asking for it. I think we still struggle with the same questions about who's the right patient, and mainly also setting expectations, right? Because we do see a lot more recurrence in focal therapy compared to whole gland treatment. So if you're telling a guy that's got, 3+4 in the right apex, or even 4+3, and they're focal, so they want to be treated, that's fine, and that is an option for that person, and they may do very well with that. But I think the thing that we have to be able to clarify to them is there is a balance there. I mean, on one hand, you may have a more extreme side effect because of you got a whole gland treatment, but your recurrence is much less. Focal therapy is going to have less impact on your side effects, but the trade-off is your recurrence
Right.
likelihood is higher. So, it's kind of it. I think,
You
I
know,
see
there,
patients go one way or another depending on how they look at that.
let me ask you, okay, focal is partial gland treatment, but let's say somebody has some 3+3s and I don't know, some 3+4s. With focal, can you just take out the 3+4s and leave the 3+3s in place, or do you take everything?
I mean, for the most part, when you're doing focal therapy, you're ablating. So you're not taking anything, it's not like a surgical. I mean, there are some groups looking at things like that, but for the most part, you're doing cryotherapy and freezing, a quarter of the gland or half the gland, or you're doing HIFU and heating it. So if you have a 3+3 that's in the same area as your 3+4, you'll treat it just to get it done. But let's say the 3+3, which is on the other side of the prostate, and your 3+4 is what you're going for, then you just do the 3+4 and you survey that 3+3, right? And that's what a lot of places will do. They won't necessarily go after the 3+3s. But I think the thing that happens is in terms of expectation is, you have a 3+4, let's say, and you go after that in the right apex. Now, the rest of your prostate, your whole left half has not been treated at all. The upper part of your right may not have been treated. Your likelihood of recurrence is much more than, let's say, you had a radical prostatectomy or radiation. But the expectations are a little bit different. Hey, I didn't do surveillance, I did a focal therapy, I did something. So, it's managing the expectations, I think, more than anything else. Because we have a lot of patients that do focal therapy and then they feel like their cancer has been completely treated. They don't want to do a subsequent biopsy. And that could be, where they get into some trouble because you do have a higher recurrence rate. And so you have to monitor that accordingly.
So, Dr. P, I have a question to ask you from something you said. You talked about seeing on a biopsy a lot of 3+3s, and that you might want to follow and see what those 3+3s did. My basic prostate cancer education is a little similar to yours, except from the other end. I was treated at UCSF. I served on the patient advocacy committee there. So I worked closely with Matt, and my own doc was Matt Roach, and with Peter, and with Chuck Ryan. And I was always told that a Gleason's grade cell, it never changes its grade. If it's a 3, it stays a 3, and it doesn't morph into a 4. The 4 came from some other type of genetic combination and started as a 4. Now we may have missed a 4, so later on down the game, we do another biopsy, we find that 4. But what is your view and we get asked this question a lot, by the way, which is why I'm asking you.
Yeah.
What is your view on whether a cell changes its nature?
Yeah, it's a great question. And I don't think anybody really knows the answer to that. So when I was a fellow, I remember we had a big paper, like a journal club with Cooperberg discussing that, the clonality of 3+3s. So we do know that some 4s start as 4s. They didn't appear to come as 3s. And we do know that some 3+3s have morphed into 3+4s. So I don't know for sure that we could say a 3+3 will always stay a 3+3. And especially when we're talking about some of the issues and limitations we have when we're talking about a biopsy and not being sure exactly where it went and things like that, But I have patients on this mass trial that we've been following with MR guided biopsies, and we're only seeing 3+3s in their first guided biopsy. Then we see more 3+3s, and then finally we're seeing more four, little bits of four show up. Now, could that four have been a very small amount on the first biopsy and totally separate? Who knows? We'll never really know. But my personal belief is I do think you see these threes that can become fours. But that's only part of the story. I think there are some threes that will never turn into anything, and I think there's some cancers that'll come right off the bat at four. I think there's so much we just don't understand about prostate cancer and how it progresses.
Thank you. I really appreciate that answer, because we get asked it all the time in the groups, not in this group so much, but in the low intermediate and in the advanced groups, it's a big question.
Yeah, and I mean, here's the thing too, right? Like, I do think that we always have a big distinction between, classification versus true progression. Classification meaning it was always there, you just found it later, versus someone that really did progress. But for classification, it's usually going to be in the first 18, 20 months or 24 months or something that, it was really there and now you're seeing it on another biopsy. But if we felt like with MR guided biopsy and all the tests that we have, and we've done a biopsy and we really feel confident that this person doesn't have anything worse than the Gleason 6 we found, then if we really felt those Gleason 6 are never going to change, you could almost stop surveying that person technically, right? I think the reason we continue to watch it is the fact that we don't know, and the fact that even though we feel confident there's nothing else going on there, it's those 3+3s that may actually change into something.
So then what do you do with a guy who has 11 out of 12 positive cores and they're all 3+3?
Yeah, I mean, a lot of it depends. I mean, so I have seen guys like that who have extracapsular extension, like where you take them to the OR and they have something coming out of their capsule. Now, do they metastasize? Usually not, but my pathologist will always tell me Gleason 3+3 will have ECE, and can spread past the capsule and therefore does invade. So while it doesn't have like all the metastasis concerns, there's definitely concern about progression. So I think a guy with 11 out of 12 cores, likelihood is he's probably got high volume on those cores. It's not likely that he's just a 5% in each core. He's probably got 50, 60, 70%. That's a guy that I probably would treat, and most times you find some 3+4 in there. Now, did we win that battle? I don't know. If you take it depends on how you look at these things. If you look at every guy with even 3+4 cancer at whatever age they find, and you were to say that guy lives the rest of his life, is he going to die of prostate cancer? Probably not. So I think there's still a lot that we do today because we're so uncertain about what that future looks like. Before we would say this about a guy who had 2 or 3 cores of Gleason to treat, right? Now we're not saying, oh, that guy definitely doesn't. So maybe in the future we'll get to a point where we're saying, no matter how much, as long as it's 3+3, we're okay. But I don't know that we're there yet, because most times when someone says I don't treat low risk, they're automatically saying low risk, low volume. But when you put up that slide of 10 cores positive, it's hard to say I wouldn't treat that guy.
Yeah, the $64,000 question that I hear most often in the active surveillance group, I shouldn't say most often, but very frequently, and you did address this in passing, but maybe you'll dig into it a little more, is at what point do you treat a 3+4? A guy comes in, he's 3+4, you're comfortable letting him survey. When does that 3+4 require intervention?
Yeah, I think the reason I mentioned it in passing is because I have no idea. I mean, nobody knows, right? So it's hard to kind of come out and set this is the cutoff, because you could say, okay, well, 4+3 is going to be my cutoff. But again, that depends on the biopsy you did and what that core is going to look like. You move that needle a little over, it could have looked like a 4+3 instead of the 3+4 that you ended up getting. And so I think you have to almost stop looking at triggers at that point, like say that there's going to be a hard shelf, you're good, you're not good, and kind of just look at just progression itself. If you now were 1 core 3+4 and now you've gone to 2, or you're seeing that the percentage of 4 that's in there is moving, to me that's kind of a little bit of a sign right there, because where I get where I get difficult, or where it's hard, is people want triggers or cut points with the hope that, hey, I can go right to this point, and as long as I don't hit that point, I'll be okay. I'm not going to metastasize. But that's not really how it works. We don't know, right? So the more four you get, the more likelihood you are to have progression, to have metastasized. So that's the trigger. I kind of say, look, your cancer is progressing. It is a 3+4. It could do something. If we're watching it, we got to be watching it very carefully. But it's hard to give that kind of endpoint, because I don't think there's one like that exists.
Yes,
You know,
Sanoj.
I was lucky in that respect. I was diagnosed 4+4 from the off, so I never had to wrestle with that decision. I knew I needed treatment, but
Right.
I'll bow out and leave the rest to Howard.
Well, no, thanks, Rick. But you triggered something for me. Another thing that commonly comes up are concerns from men who are worried that biopsies are going to seed cancer somehow. It's going to spread cancer, right? Joe and I were at a meeting last Saturday where some guy had a big fat conspiracy book, and that was one of the things that was in the book. Stay away from the biopsy because it's going to
Yeah.
spread cancer. So what's the answer?
Yeah, no, I mean, I get that question a lot as well. And I mean, I don't think we have any evidence to see that. The surveillance guys probably get biopsied more than most people do, and they have the least progression that we see. So if there was any truth to it, and especially in the past where we were biopsying surveillance guys every single year, if not more, we didn't see those kind of cancers progressing and taking off. So there's just no evidence at all to support that.
Here's something basic that somebody asked, which was, can you define what a confirmatory biopsy is?
Hmm. Yeah, I mean, really, it's just doing a second biopsy after you've been diagnosed with cancer. That's the main thing, and the main purpose is to confirm that you truly are low risk, low volume. So I think it had more of a role. I think there's still a lot of people that believe in confirmatory biopsy, but I think traditionally when we would talk about confirmatory, it would be, hey, you got diagnosed with what we think is a low volume indolent cancer and you're eligible for surveillance, but we need to do another biopsy within 3 months to make sure that you don't have something worse, right? And this was, I think, more of a period where we were worried that any Gleason 3+4 or higher volume of Gleason 6 is going to metastasize and quickly do something. So we'd want to, there was a period where we were really trying to find every cancer or every bad cancer and go hunting them down, making sure that they didn't persist. So I think nowadays, we feel much more comfortable telling a guy that, hey, you were diagnosed with a cancer, it's not likely to hurt you. We probably will need to do some more biopsies to make sure it's not getting worse, but we don't need to do anything for at least 12 to 18 months. So that may not seem so much like a confirmatory biopsy, but I think the reason it got its name was because it was often done shortly afterwards.
But these days, it's a year to 18 months.
Yeah.
Somebody else asked a question, Adam, about confirmatory biopsy, but here he's saying in the case of BPH, in other words, enlarged prostate, plus cancer, he says, how about taking 6 months of finasteride or dutasteride to shrink the prostate before a confirmatory biopsy after 3 to 4 years, not in order to treat BPH, but to achieve a more reliable biopsy. I'm not sure if I follow that, but if you do, maybe you can explain it.
Yeah, I mean, so I think the thought process is maybe, you're worried about sampling error because you have a big prostate. So if you go on finasteride, shrink it down, maybe your biopsy will be a little more likely to find cancer because the needle in the haystack is a little bit bigger, so to speak. I think there's some merit to that. I mean, look, the Redeem trial, which randomized guys to finasteride versus no finasteride, and they're all low risk, I believe, showed a benefit in guys that took it. They had less progression. They were more likely to have a negative biopsy. There may be some truth to the fact that finasteride may treat very small volumes of low risk indolent disease. There's plausible biological mechanism for that. So I think there are benefits to putting people on finasteride when they go on surveillance, but there are some side effects to the medication. Some guys will get some gynecomastia. It does have some impact on ED. So do I put everybody on it? No. If they have a big prostate and they're having symptoms from it, I think there's a benefit to putting them on it because they get the surveillance benefits and the BPH benefits. But I don't put them on it just for surveillance.
Okay, now Richard asks, and we have a lot of Richards. That generation had a lot of Richards. One doctor told me, he said, that a biopsy could possibly cause ED. Is that a fact?
There have been studies kind of showing repeated biopsies, and you see different things, but I think that was more effective aging, than anything else. I don't think the biopsy will cause ED. You're not really, causing any significant damage to the nerves or anything like that in there with the small core needle that we're using. So I haven't seen that.
By the way, in your practice, what role does diet and exercise play? Can you change your risk factors with diet and exercise?
Yeah, I think you can. There have been some studies looking at that. I think Peter Carroll's group actually did something where they went on a very intense exercise and diet program, and their actual DNA and prostate cancer kind of risk factors changed a little bit in terms of just their DNA. And we know that there's a lot of lifestyle factors that have been associated with prostate cancer in terms of obesity, food consumption, red meat, things like that. Exercise is all playing a role in studies on prostate cancer and progression. So you do see this kind of trend where guys will get diagnosed and some of them will become very, diligent about their health and start living very, very healthy lifestyles. And I think that does speak to something about what their cancers are going to do. Now, does it mean that if I do a good exercise, I'll never progress? No. But do I think there's some benefits to it? Yeah, I do. How quantifiable are, I don't know.
Now, what about?
Can I just say, Dr. P, that June Chan and I pitched that to Peter.
Yeah.
Yeah. It was 2009, I think, and we were trying to get some stuff done on exercise, and the only exercise stuff was being done for breast cancer, and June really wanted to get it, and I had a meeting with June, and I said, we really should see if we can get Peter to get some money from PCF or November, and she said, well, why don't you come along with me? Because I've asked him several times, and and we're not getting anywhere. And he did. They did get money, as you know, from
the DoD.
And June was able to do that study.
Mm-hmm. And there's another group in Calgary, actually, I think, that had done a randomized trial of incorporating like HIIT training, like high intensity interval training.
Right.
And they've seen great results,
well,
with that.
The lead researcher on that is speaking to this group in December.
Oh, great.
So
well, there you go. You'll get a lot more on that then.
Yeah. Well, let's see. A question from Joe. Do you encourage germline testing in addition to genomic testing?
For surveillance?
Yeah. Or you can go broader. And by the way, we've reached the traditional endpoint, but if you could stick around,
yeah, sure.
Would you? Okay.
Yeah, I don't traditionally just for surveillance, because a lot of it comes down to what are you going to do with the information? So for example, the biggest implication is if you have a guy that's BRCA2. We know those guys tend to have more advanced cancers. They're more likely to progress, but I can't say that doesn't mean they couldn't have surveillance. You just watch them a little more carefully. But again, the likelihood of those BRCA2s are very, very small. And to kind of say, you're going to send everybody for germline testing, I just don't know that the benefits would be there. I think right now, the only people I'm really doing that in are those guys that present with metastatic disease. We're doing somatic and germline testing in them, as per guidelines. But we haven't really been doing it with the more localized.
Yeah, let me ask you about liquid, so-called liquid biopsies.
Mhm.
Now, Grail was, like a huge bet, as far as investment. And if the company got sold for billions of dollars, and they ran some tests. I think it was Dr. Eric Klein at Cleveland Clinic ran the studies, and he's a urologist and he's a prostate guy. And what the study found was that the liquid biopsy, worked pretty well for about 60 cancers. But prostate cancer, ironically enough, wasn't one of those. Especially low risk, because there isn't many cancer cells being shed. But okay, that's one liquid biopsy. Then we hear from Dr. Klotz. He's involved with something called the Sentinel test. If it, maybe you can go into the liquid biopsy some more. He by the way predicted that this is going to be one of the biggest things coming in the years ahead. So maybe you can give us some perspective.
Yeah. So, I mean, the first one I think you were talking about is kind of like one of those multi-cancer assay panels, right? Like where they're
Yep.
testing for, yeah. And again, I think that's something like the NIH and FDA are looking at very closely right now because they want to see more of those, I think, out there. But then how much noise you're going to get in certain areas, I think, is a condition or an issue that they're seeing a lot with that. Now, as far as a lot of these other liquid markers, I know a little bit about this Sentinel one. I think it's looking at urinary exosomes or extracellular vesicles and getting something out of that. I'm not entirely sure. But there's a number of these markers, right? Like exosome, DX is the urine test that can be used as a liquid biopsy. The 4K score technically is a liquid biopsy. I mean, they're all examples that are out there and being used. And they all help in terms of improving, decision making for who needs to go for a biopsy. But I guess the thing is, the biggest problem that we have is you have a new liquid biopsy test that comes to the market, and then it's only been validated in a certain number of patients, has not had a lot of thorough validation, and they rarely get head to head with any other marker, So we're going to get to a point where we have so many different markers to choose from. We're already kind of there, knowing which one is the best one, what's the cutoff I could use, and how it worked in a population like my patient population, are things that we don't often have a lot of criteria for. So if I look at, for example, the two ones that I'm more familiar with, 4K score or exosome, they'll have a cutoff of, let's say, 7.5% for 4K or 15.6% for exosome. Now, those cutoffs are there to tell me that if you have a smaller number than that, then the likelihood that you got a bad cancer is very, very small. So I can feel confident that you don't need a biopsy if your number is underneath those thresholds. But that's because those tests were geared towards kind of finding that threshold under which you should be okay. The problem is they're going to have a lot of false positives because a lot of guys above that threshold are still going to be okay, but they'll signal positive because the test threshold is really low. So the tests are made based on not missing a cancer. And whenever you're making a test on not missing a cancer, you're going to have a lot of false positives because you're trying to have a low threshold. And ideally, you don't want to miss cancer, so you don't want to have a high threshold, but it's going to be somewhere in the middle, I think, is going to be the key. So to me, I mean, I think there's a role where MRI and biomarkers will probably play a role. I don't know that the clots marker is going to be any better than the other ones we have there. And,
Well, he's claiming, I mean, don't quote me on it, but as I recall, it was, close to 95% accuracy. And, and I think he was suggesting the ability to use this urine test to distinguish between high risk and low risk. I mean, is this over-promising? Or if this is true, is this revolutionary?
No, I mean, all these markers come out saying that, they all have like pretty high negative predictive values and say they can reliably distinguish. But the thing is, then they have to be validated and validated again and seeing how they perform, right? And then why would you use this marker versus one of the other ones that are out there doing very similar things? So I don't know. So far, there's been lots of different tools that have come out to say that they're going to be the holy grail. These genomic markers, when they first came out, Eric Klein used to say it doesn't matter whether you hit the Gleason 6 or the Gleason 9. The genomics on the Gleason 6 will tell you about the Gleason 9 you missed. We learn now that there's not true. That these markers only tell you about what you hit, not what you didn't hit. So time will tell.
Now we got a question here from Larry, and it sounds like transperineal, but it's not. It's paraneural invasion. How does paraneural invasion in biopsy factor into active surveillance decisions? So I think you got
Yeah.
to define for us what paraneural is.
Yeah, perineal is if on the pathology, the pathologist may comment that they're actually seeing some tracking of prostate cancer along the nerve fibers, like the neural area. And, the concern was that there's been mixed studies. Some studies have said if you see perineal invasion, it's indicative of a higher likelihood of extracapsular extension and radical prostatectomy. So those patients should be, maybe not eligible for surveillance. It also could be something that's just a factor of the way the path was read or something like that. So I think if you're seeing somebody has lots of course positive and perineural invasion, they're likely not a surveillance candidate anyway, and that may speak to there being a more aggressive cancer there. But if you're talking about perineural invasion was just seen in one or two cores of Gleason 6 and otherwise everything looks okay, I don't know that it would change me just the perineural invasion per se, but I would have that path reviewed. I'm a big believer in having your path reviewed at experts' places because there is a lot of variability in pathological grading, and that can change things drastically, especially for 3+4s or anytime you're seeing something, that may not be quite clear cut on the pathology, like intraductal or cribiform or anything like that.
You mentioned MRI increasingly playing a role in diagnosing prostate cancer, and Rick is asking for comment on the comparative value of MRI with and without contrast, or what type of patient can get away without contrast versus which patients need it. I mean, this is hearkening to back, a couple of years ago we were fussing about gadolinium, and now we're fussing about transperineal. So to get back to Rick's question,
It's
what is?
Question, actually, it's not my question. It was Daniel's question.
Oh, okay.
But in terms of the role of contrast for MRI.
Yes, in terms of the role of contrast.
It's definitely getting minimized. So when I look at all my MRIs still, but I pull up the T2 weighted image and I pull up the restricted diffusion. I never really look at the contrast. Now there are some radiologists that feel the contrast does add something to them, and they do find some value, like NIH, for example, who are big superstars in the MRI world. They're more believers of contrast, and I think their radiologists have had a lot of experience and they've just used it. But I think the problem is that the contrast, can be very different in different protocols depending on how often you're imaging the patient. So it brings in a lot of variability. And Westphalen had shown that there's a lot of variability, I think, in just that how you read the DCE. So a lot of like the PIRADS committees have now started to de-emphasize the role of the contrast. So I think if someone is not able to get it, it doesn't impinge on them, it doesn't compromise them in any way. And there's been a lot more talk about getting a biparametric MRI where you eliminate the contrast because it would be much faster, it would be less expensive, you spend less time in the scanner, less risk because you're not getting an IV or contrast or anything like that. So I think moving forward in the future, it probably would be the way we get closer to, so to speak, a screening MRI.
So in terms of gadolinium, in particular? Do you,
Mhm.
I mean, a couple of years ago, they were talking about, class action suits and, the contrast crossing the blood-brain barrier. And a lot of people were very scared. They may still be, but I don't hear that much about it lately. But what do you hear
Yeah.
on your end?
I mean, we do a lot of MRIs. I've never had much issue with any concerns like that. I mean, it's definitely going to be safer than, like iodine. I think you do have to worry about people that may have some chronic renal insufficiency because they can have some issues and build up. But again, that's where then I would just say don't give the contrast. I mean, I think the benefit is very minimal, and when you get the adding the contrast. So eliminating it is to me not that big of a deal. And I think you're seeing that more through all the panels.
I gotcha. I don't know. Anybody else with anything? Maybe we can let the good doctor go unless somebody else has something. Any burning questions?
Yeah, Howard Ira.
Okay, Ira, but be brave, I guess. Ask your
Yeah,
question.
the doctor, I was just wondering, uh, generally when one gets a MRI order, the urologist orders the MRI, and it's the urologist that kind of guides whether he wants contrast with that MRI or not. So what if a patient were to say, look, um, I don't want any contrast, and he poses it to the doctor, and the doctor says, well, you have to have contrast. So there ensues some type of a conflict there. So it would behoove the patient to have the knowledge of why he doesn't want to have the contrast. And I think if he's educated as to it doesn't make much difference, as you're saying, I believe, it doesn't make much difference. But then again, they probably would argue that their radiology department needs the contrast. I'm just wondering, how does one
Yeah, wrestle with that. So
yeah,
it's a good question. So I think, there's a lot of different reasons why people will want something versus a not. I think so for example, the guidelines of what is considered an efficient multiparametric MRI still requires a 3T magnet and contrast, right? So in that sense, maybe radiologists will say that has to be our test in order to meet those standards, because that is the current standard for multiparametric MRI according to quality. So if you're setting an order, then that would be the order that automatically goes through, and that's what radiology is going to try to push. And so when I meet a patient and I order an MRI, I usually will order the standard one with and without contrast, just because that is the standard. And some radiologists, depending on where you are, may actually use that contrast. Now, if the patient has that discussion with me and says, look, I really don't want it, even if they have perfect renal function, or let's say they don't have great renal function and maybe shouldn't have it, then I just write in the comments that not going to have contrast or something like that. I've never had pushback from my radiologists about that. As long as they can have a reason to explain why that patient didn't get it, and they may say something in the report that, hey, this was not we'd eliminated contrast, so it was not a full multi-parametric MRI or something that covers themselves that way. Because I think that's part of what they're thinking about in that kind of decision, and I don't want to speak for every radiologist out there. There may be some that do find the contrast useful. It's not like there's unanimous consensus in the field, but I would say the majority, have found that it is tending to fall out of favor and play less and less of a role.
Yeah, so
Well,
actually
listen,
radiologists can read the MRI if they're proficient in it without the contrast.
Yeah. The other two sequences that they'd be looking at are going to be no different, just, by
Yeah,
lack of contrast.
yeah. Thank you. Thank you.
okay. Well, I think we're going to call it a night here. But
Can I ask a question, please? Could you talk to multifocal lesions for various grades of cancer?
This is
So
fine.
I think we might need to schedule a separate session for that. That's not something we would be able to get into in the closing minutes.
I mean, I could, yeah, I mean, if you're talking about a multifocal I mean, that's the majority of cancers, right? Because they do tend to be multifocal and high grade, but those are the ones you would probably not do a focal therapy for, and you'd do a whole gland treatment, like
I mean, but
radiation or surgery.
how do you know?
Well, you're
Like,
going to base it, you're basing it on the MRI, you're basing it on the biopsy, you know, depending on where you're seeing it. If it's not just in one core and multiple lobes, things like that, then that's going to determine the multi versus unifocality of it. And then you get the grade.
Okay, well, I think we really got to call it quits now, but thank you, doctor, for joining us and answering so many questions. And maybe you can come back again. So
No problem.
okay,
Thank you.
So
Thank you, Doc.
No problem,
you,
guys.
Doc.
It was great being with you. Thanks for the invite.
thank you.
Very much.
Bye.
We're glad to have